Hello class, welcome to Mrs. Korea's Week 3 lecture, Nursing Care of Prenatal Women. We'll be discussing on focused obstetric examination, nutrition and weight gain during pregnancy, and health education during this week. Focused obstetrical examination. We'll start with head. You will see more healthier head during pregnancy. Look for hypertrophy of gingival tissue, nasal stuffiness, and increased tendency to nosebleeds. Neck, look for thyroid gland enlargement, which is very common. Lungs, evaluate for adventitious sounds. Heart, look for systolic murmur. Skin, examine for chloasma, linea nigra, striae gravidarum, and evaluate skin color, which is consistent with ethnic background or not. Look for lesions or indicators of drug use. All these changes you have learned in physiological changes during pregnancy, so you will see a lot of repetition of these topics. Examination of breast should be done in recumbent position. Please remember to keep a wedge under one of the hips to prevent supine hypotension syndrome. Look for skin changes, and this was described in your week 2 lecture. Abdomen should be assessed for shape, presence of scars, linea nigra, striae gravidarum, and bruising. And observe and palpate fetal movements. Fetal movement is felt by mother between 16 to 20 weeks. This is very important. Please remember this. And a primary gravida notices movement between 18 to 20 weeks. Multigravida notices fetal movements by 16 weeks. Evaluate uterine size, fetal position, and fundal height. Fundal height is an indication of uterine size. Fundal height measurement correlates to the weeks of gestation from approximately 22 weeks to 34 weeks gestation. And I want you to refer table 9-2, and it explains well fundal height week-wise. Leopold's maneuver. I have demonstrated this on first day of clinical. The first one is fundal palpation. This is to determine fetal body part that occupies uterine fundus. Second one is the lateral palpation. This is to determine the location of fetal back. Third one is the Pavlik maneuver. This is to confirm presentation and determine engagement. And the fourth one is the pelvic palpation. This is to determine fetal attitude and extension. Fetal heart auscultation. The normal fetal heart is between 110 to 160 beats per minute. Electronic fetal monitoring should be done on high-risk pregnancies. A non-stress test to evaluate fetal heart rate in response to fetal movement and uterine activity. You want to see a reactive test, that is the desirable result. And the heart rate accelerates by at least 15 beats per minute for at least 15 seconds with at least 3 acceleration episodes in a 20-minute period of monitoring. Then it is called a reactive test. Examination of vagina and pelvis. Examine external genitalia. Look for presence of pubic lice. Vaginal infections may be indicated by redness, edema, and or an offensive vaginal discharge. Check for presence of lesions. Check for condylomata, like in human papillomavirus, vesicles like in herpes, ulcerations like in syphilitic chancre, bruising or tenderness, which is possible from trauma or abuse. Check for color, presence of inflammation, lesions, ulcerations, or erosions on vagina and cervix. And the cervix size is about 1 inch in length, and external cervical os is round in nulliparous, that is a woman who has never been pregnant before, and slit shape in multigravida. Perform bimanual examination. It is an evaluation of uterine shape, position, and size. Check for uterine size. Check for hydramnios, which is polyhydramnios, and that is the increase in volume, and oligohydramnios, which is decrease in volume. In your textbook, you will see the term hydramnios, which represents polyhydramnios. And the provider also may perform rectovaginal examination. That is, the provider will insert one finger into the vagina and one finger into the rectum, and that's how they examine this. The next thing in focused assessment is performing clinical pelvimetry. This is to recognize any abnormality in shape that may be associated with a difficult or traumatic vaginal birth. And you can see 4 basic types of pelvis. They are gynecoid pelvis, which is the most common one, which is otherwise known as a female pelvis. The next one is android pelvis, otherwise known as male pelvis. Then anthropoid and platypeloid. And I want you to read the below terminologies from your textbook and find answers for this and add notes. What is a diagonal conjugate? What is a true conjugate? And what is ischial tuberosity? Nutrition and weight gain. The calorie requirement increases 300 kilocalories per day from pregnant needs. Protein is important for growth of maternal tissues, including uterus and breast, and for development of fetal tissues and organs. And protein increase is only a modest increase. The sources are dairy products, soy milk, soy cheese, bean, legumes, meat, poultry, fish, and egg. And remember, they need to be cooked thoroughly. A pregnant woman needs to drink at least 8 to 10 glasses of water per day. Iron requirement is 27 milligram per day. Folic acid or folate, the US Public Health Service and ACOG recommend 0.4 milligram daily for all women during childbearing age and 800 microgram during pregnancy. Why? I want you to find the answer for this and add to your notes, please. The calcium requirement is 1300 milligram per day, and the vitamin D RDA during pregnancy and lactation is 600 international units, that is 15 micrograms per day. Influences in weight gain. The physiological factors are increase in blood volume. And how much is the increase in blood volume? You want to know that. And placenta and fetal body weight also adds to the weight gain. Social influences are inability to purchase food, unplanned pregnancy, and intimate partner violence, inadequate dietary intake, inadequate physical activity. And the management is we need to calculate BMI and help in managing a diet plan. And daily food and fluid intake should be monitored. Factors that affect nutrition. Eating disorders such as pica, that is craving for some kind of food, anorexia nervosa, bulimia nervosa, then cultural factors, vegetarian diet, food cravings and food aversions. These all can affect the nutritional status of the mother. Few words about medications. We need to educate pregnant mothers about what medications are safe and what medications are teratogenic. Find some examples of teratogenic effect. And the teratogenic effects are more dangerous in which stage of fetal development? You probably want to know that. And educate about over-the-counter medications, herbal and homeopathic preparations, prescription medications. The FDA pregnancy categories, the pregnancy category D can cause adverse fetal effect, and category X can cause fetal risk and congenital anomalies. So these 2 categories are not prescribed during pregnancy. And teratogenic effects are also discussed during your module discussion 1. Health education on common discomforts of pregnancy. These discomforts are caused by physiological changes during pregnancy, which we have already discussed in the previous lectures. So we need to tell them that these are common and there is no abnormality in this. These are due to normal physiological changes. These discomforts are nausea and vomiting, ptyalism, fatigue, nasal congestion, backache, and leukorrhea. Pregnant women may experience urinary frequency, dyspepsia, flatulence, constipation and hemorrhoids, dental problems, leg cramps. All these are due to physiological changes. Pregnant women may also complain dependent edema, varicosities, dyspareunia, nocturia, insomnia, round ligament pain, hyperventilation and shortness of breath, numbness and tingling of fingers, supine hypotension syndrome. All this could be due to physiological changes or psychological changes during pregnancy. Education on signs and symptoms of dangers of pregnancy are very important so that the pregnant woman will know the signs and symptoms, and that will alert them and will help them to seek medical attention if necessary. And we will be discussing under first, second and third trimester, and these topics are, some of them will be included in week 4 lecture in detail. Dangers during first trimester: severe persistent vomiting. This can be due to multiple gestation, thyroid disorder and hydatidiform mole. The management is oral fluids, small frequent meals and emotional support. Abdominal pain and vaginal bleeding may indicate spontaneous abortion or miscarriage. The management is bed rest, emotional support and contacting provider. Indicators of infection are chills, fever and anorexia, and UTI may also occur, and this usually accompanied by burning, micturition and or fever, and they're usually treated with antibiotics. We need to educate patient, and please read from the textbook. Maternal complications during second trimester are preeclampsia, that is increase in blood pressure after 20 weeks of gestation with proteinuria. Please read from your textbook, and we'll be discussing more in week 4 lecture. Premature rupture of membrane, as it indicates, it ruptures early, and also we'll be discussing this in week 4 lecture. Preterm labor, educate on signs and symptoms. This is very essential, and also teach on true labor and false labor. And the true labor should be differentiated from Braxton Hicks contractions. You know what is Braxton Hicks contractions? You want to know that. Fetal complications during second trimester are decreased fundal height, may indicate intrauterine growth retardation. Increased fundal height may indicate multiple gestation and fetal macrosomia or hydramnios, which is polyhydramnios. And hypoxia can result from maternal hypertension. You may see irregular or absent fetal heart rate, preterm birth, infection from premature rupture of membranes, and absence of fetal movement after quickening. And what is the management? I would like you to read it from the textbook. It is important. Complications during third trimester. Maternal complications are gestational diabetes, which is diabetes during pregnancy, then placenta previa and abruptio placenta. These two will be discussed in week 4 lecture in detail. Placenta previa is the implantation of placenta in the lower uterine segment, and abruptio placenta is premature separation of the placenta. And how to differentiate these two clinically? Placenta previa, the vaginal bleeding will be painless. That means there is no pain associated with vaginal bleeding in placenta previa. But in abruptio placenta, the vaginal bleeding is painful. It is painful bleeding. And it is the premature separation, so it is very painful, and this is how you differentiate them clinically. This used to be a midwifery question when I learned midwifery. And the fetal complications are same as of second trimester, but the hypoxia related to poor placental perfusion may become more of a threat during this time. That comes to the end of week 3 lecture, and thank you for listening.